everyone. I am Dr. Deepak Pahwa, and this is the first lecture of our series on regional anesthesia for upper limb surgeries. The objectives of today's lecture include anatomy of brachial plexus, the brachial plexus block at interscalene level, the supraclavicular level, and the infraclavicular level. First of all, to start with the anatomy of brachial plexus. We all know that brachial plexus provides sensory, motor, and autonomic innervation to whole of the upper limb. It was in 1884 that Halsted for the first time used cocaine to block brachial plexus. Brachial plexus is formed by ventral rami of C5, C6, C7, C8, and T1 spinal nerves. A prefixed brachial plexus is one which has got innervations from contribution from C4 spinal nerve, while a postfixed is the one which has got contribution from T2 spinal nerve. These rami, they then pass through the intervertebral foramina and then pass in between anterior and middle scalene muscle through the interscalene groove in a caudal and anterolateral direction. While passing laterally and caudally between the two muscles, between the scalene muscles, they unite to form trunks. Superior trunk is formed by C5 and C6 roots. Middle trunk is formed by a C7 spinal nerve root, while inferior trunk is formed by a C8 and T1 nerve root. Superior and middle trunk, they lie superolateral to the subclavian artery, while inferior trunk, it lies dorsal to the subclavian artery in the corner pocket. This is of relevance while we are giving brachial plexus block at supraclavicular level. These trunks, they emerge from the interscalene groove and start moving towards the upper surface of first rib. Trunks then divide into two divisions, anterior as well as posterior divisions. These divisions, they rearrange around the axillary artery to form cords. Cords are named as per their relationship around the second part of axillary artery. Lateral cord is formed by anterior division of superior and middle trunk. Medial cord is formed by the anterior division of inferior trunk, while the posterior cord is formed by the posterior division of all the three trunks. At the lateral border of pectoralis minor, these cords give rise to 5 terminal branches. These are the ulnar nerve, the median nerve, the musculocutaneous nerve, the axillary nerve, and the radial nerve. Functionally, lateral cord supplies the proximal flexors of the upper limb. Medial cord supplies the distal flexors of the forearm, while the posterior cord supplies all the extensors of the upper limb. There are various terminal and pre-terminal branches of the brachial plexus. From roots, there are 2 branches that arise. This includes dorsal scapular nerve and the long thoracic nerve. From trunk, suprascapular nerve and the nerve to subclavius arise. While from the cords, from the lateral cord, lateral pectoral nerve, musculocutaneous nerve, and the medial root of the lateral root of median nerve arise. From the medial cord, the medial pectoral nerve, medial brachial cutaneous nerve, medial antebrachial cutaneous nerve, ulnar nerve, and the medial root of median nerve, they arise. These can be remembered by the mnemonic M4U. The posterior cord gives rise to upper subscapular nerve, thoracodorsal nerve, lower subscapular nerve, axillary nerve, and the radial nerve. These again can be remembered by the mnemonic ultra. Now coming to the brachial plexus blocks. First of all, we'll discuss the interscalene brachial plexus block. Now in interscalene block, the drug is deposited in the groove between anterior and middle scalene muscle. This gap is called as interscalene groove or gap. Now this gap is filled with fat and connective tissue. Interscalene groove is continuous with the epidural space. Prevertebral fascia, it covers the nerves and the prevertebral muscles. Some authors consider this as brachial plexus sheath. This block targets the brachial plexus at the level of roots and trunks. Phrenic nerve, which arises from C3 to C5 ventral rami, and it passes vertically down the anterior surface of anterior scalene muscle. Indications for interscalene brachial plexus block include shoulder surgery. This includes any shoulder surgery like shoulder arthroscopy, rotator cuff repair, open repair of proximal humerus fractures, and shoulder replacement surgery. Contraindications to this block include patient refusal, infection at the block site, actively bleeding patient who is on anticoagulants, contralateral phrenic nerve or recurrent laryngeal nerve palsy, impaired lung function, pre-existing neurological deficits in the same limb. For landmark guided approach, there are two techniques. These are the classical or the Vinnie's approach and the posterior approach. Posterior approach has now been abandoned because of the high risk of complications. We'll discuss the Vinnie's technique. Patient is positioned supine with head turned towards the opposite side. Patient is then asked to lift the head so as to palpate the clavicular head of sternocleidomastoid muscle. Fingers of the non-dominant hand are kept along the posterior border of sternocleidomastoid muscle. Patient is then asked to relax. Fingers of our non-dominant hand, they are now resting on the belly of anterior scalene muscle. Fingers are then rolled across the belly of anterior scalene muscle so as to fall in a lateral direction, so as to fall in the interscalene groove. A 22 gauge 5 centimeter short bevel needle is then inserted between the fingers at the level of C6. A nerve stimulator is connected to the needle. Initially, the current strength that is kept in nerve stimulator is around 1 milliampere. The motor response is then elicited, and gradually the strength of the current is reduced to 0.2 to 0.5 milliampere. At the end point, 15 to 20 ml of local anesthetic is injected after negative aspiration of blood and CSF. In Vinnie's classical description, paresthesias were elicited. Now, paresthesias should always be sought below the shoulder because paresthesias at the level of shoulder can be because of stimulation of suprascapular nerve in or above the interscalene groove. While eliciting motor response, stimulation of deltoid, biceps, triceps, pectoral, or any teaching in forearm or hand signifies successful placement of the needle. Muscle twitches of serratus anterior indicate stimulation of long thoracic nerve. Rhomboids indicates stimulation of dorsoscapular nerve, while trapezius indicates stimulation of spinal accessory nerve. All these stimuli indicate that our needle is placed posterior to the interscalene groove. Similarly, hiccups, if they are encountered while giving this block, they indicate that probably phrenic nerve is getting stimulated. So phrenic nerve, as we know, that it lies on the anterior belly of anterior scalene muscle. So we need to go deeper to give this block. For giving continuous interscalene brachial plexus block, the technique is almost the same as single shot. We first locate the interscalene groove. Once the interscalene groove is located and the endpoint is reached, we insert the catheter for 3 centimeters beyond the tip of the needle. We should always check for intravascular placement of the catheter by injecting 3 ml of 1% lignocaine with adrenaline. Now, continuous interscalene brachial plexus block is technically more challenging because of shallow position of interscalene groove, and of course, because the needle is difficult to stabilize in such a shallow groove. For ultrasound guided technique, the position of the patient is same as that of Vinnie's technique. Patient is placed supine with head turned to the opposite side. Required cartilage is identified. The area is cleaned and draped. A linear high frequency transducer is kept just below the cricoid cartilage level in a transverse orientation. Carotid artery is first identified. Transducer is then moved laterally to identify anterior and middle scalene muscles. Brachial plexus is identified as hypoechoic, that is the black colored structures lying between the anterior and middle scalene muscles. These usually give appearance of a traffic signal. As we can see over here, C5, C6, C7 nerve roots can be identified over here. Color Doppler should be used to differentiate vascular structures which may be lying in the vicinity. Needle is then inserted in plane in a lateral to medial direction. The tip of the needle is aimed just next to the plexus, not in between the roots. As the needle advances and pierces the prevertebral fascia, a pop is felt. One can use a nerve stimulator at this point, uh, which is at 0.5 milliampere. They confirm that twitches in the shoulder, arm, or forearm. They confirm the successful placement of the needle. After negative aspiration of blood, 15 to 20 ml of drug is deposited. When it is difficult to identify brachial plexus in interscalene groove, one can start scanning in the supraclavicular region. We should identify the subclavian artery. The brachial plexus lies superficial and posterior to the artery. Once the brachial plexus is identified, it is traced cranially by gradually sliding the transducer in capillate direction. Never inject against high resistance in this block. It indicates intraneural placement of the needle. As I told you, it is better to inject around the plexus rather than in between the roots, because C6 and C7, they are known to be splitting proximally. So if we are injecting in between the roots, we may actually be injecting intraneurally and may cause intraneural injection and paralysis. Medial to lateral insertion of the needle is avoided because phrenic nerve, as we know, it travels along the anterior surface of anterior scalene muscle. So it may be encountered and we may inadvertently injure the phrenic nerve. For continuous interscalene brachial plexus block, interscalene groove and plexus are located using an ultrasound as described for the single shot technique. When needle is at its ideal position, 2 to 3 ml of saline is injected to confirm the position of the needle. The catheter is then threaded for around 3 centimeters beyond the tip of the needle. Position of the catheter is confirmed by injecting local anesthetic through the catheter and checking the spread of local anesthetic around the plexus using ultrasound. Catheter is then fixed on the skin by using sterile adhesive tape. Regarding the choice of local anesthetic for giving single shot interscalene block, for surgical anesthesia, 0.75% ropivacaine or 0.5% bupivacaine should be used, while for giving post-operative analgesia, either 0.2% ropivacaine or 0.125 to 0.25% bupivacaine can be used. For giving continuous interscalene brachial plexus block, 0.2% ropivacaine can be used at around 3 to 5 ml per hour for post-operative analgesia. Complications of this block include infection, hematoma because of so many vascular structures nearby, Horner syndrome due to diffusion of drug around the anterior scalene muscle towards the cervical sympathetic chain. There can be hoarseness of voice because of the recurrent laryngeal nerve block. There can be intravascular injection, so we should always use color Doppler. There can be nerve injury. There can be total spinal anesthesia or epidural spread of the drug, as we know that interscalene groove continues with the epidural space. There can be pneumothorax. There can be diaphragmatic paralysis because of spread of drug to the phrenic nerve. Now we will discuss supraclavicular brachial plexus block. Indications of supraclavicular brachial plexus block include any upper limb surgery except for the shoulder surgery. The contraindications for this block include infection, refusal by the patient, significant coagulopathy, significant respiratory compromise, and we should never give bilateral supraclavicular block. Coming to the anatomy, well, it is performed just above the clavicle. It blocks the brachial plexus at the level of trunks. These three trunks, they lie on top of each other in the supraclavicular area. Subclavian artery crosses the supraclavicular area ventral to the lower trunk. So first of all, let us discuss the origin and insertion of the scalene muscles. The anterior scalene muscle, it originates from the anterior tubercle of transverse process of C3 to C6 and gets inserted on the scalene tubercle on the upper surface of first rib. While the middle scalene muscle, it originates from the posterior tubercle of transverse process of C2 to C7 vertebra and gets inserted behind the subclavian groove on the upper surface of first rib. The interscalene space becomes wider in AP dimension as it approaches the clavicle. Now, inner border of first rib, it covers the outer aspect of pleural dome. And anterior scalene muscle, it attaches to the superior surface of the first strip on the medial border. So while inserting the needle, one should stay lateral to the anterior scalene muscle so as to avoid pneumothorax. Also, first intercostal space lies below the clavicle. So one should never go below the clavicle while giving supraclavicular block. Again, this is to avoid puncture of pleura. For landmark guided supraclavicular block, the patient is placed supine or in a semi-sitting position with the head turned towards the opposite side. The elbow of the patient is flexed and forearm is supinated. Forearm rests on the patient's lap with palm facing towards the patient's face. The operator stands on the side of the patient to be blocked. Patient is then asked to lift his head to identify clavicular head of sternocleidomastoid muscle. A point is marked that is 2.5 centimeter lateral to this point. A palpating finger is kept at this point. The needle is introduced just scapula to this point in a direction perpendicular to the skin. Needle is advanced caudally under the palpating finger parallel to the midline with the nerve stimulator on. The nerve stimulator is initially kept at a current strength of 1 milliampere. The twitches of the finger are elicited. Once the response is elicited, the strength of the current is reduced gradually to 0.5 milliampere. And on elicitation of the response, the drug is injected at this point. If at all the redirection of needle is required, it is always done in anteroposterior direction and not in medial direction because it can cause pneumothorax. Normally for supraclavicular brachial plexus block, we inject 25 to 30 ml of drug. For surgical anesthesia, either injection ropivacaine 0.75% or injection ropivacaine 0.5% can be used. For post-operative analgesia, injection ropivacaine 0.2% or injection ropivacaine 0.125% to 0.25% can be used. For giving the continuous supraclavicular brachial plexus block, the technique is same as for single shot block. After locating the plexus, catheter is threaded for a distance of 3 to 5 centimeters and then fixed. An infusion of 0.2% ropivacaine or 0.125% bupivacaine at 3 to 5 ml per hour can be started for post-operative pain relief. Now we'll discuss ultrasound-guided supraclavicular brachial plexus block. The advantages of using ultrasound for supraclavicular brachial plexus block include visualization of pleura, the first rib, the subclavian artery, and of course the brachial plexus. It increases the safety margin significantly. The patient is placed supine or semi-sitting with the head turned towards the opposite side. A high-frequency linear transducer is placed in the supraclavicular area just above the midpoint of the clavicle and projecting into the chest cavity. The subclavian artery is then identified as a round hypoechoic pulsatile structure. A cluster of hypoechoic structures lying posterior and superficial to the subclavian artery is the brachial plexus. This is the hypoechoic structure, that is the subclavian artery, and this is the brachial plexus. Now, the first strip is a flat hyperechoic structure which is lying deep to the subclavian artery. The pleura is also seen as a hyperechoic structure which lies anterior or posterior to the first strip. It is identified by observing the sliding movement of visceral pleura synchronous with the patient's respiration. Color Doppler is used before inserting the needle because vascular structures like dorsal scapular artery, the transverse cervical artery, or the suprascapular artery can be lying in this region. After identifying the brachial plexus, needle is inserted in plane from lateral to medial direction towards the brachial plexus. Needle is first directed towards the 7 o'clock position to the subclavian artery between the artery and the first rib. This targets the corner pocket, which basically targets the inferior trunk, as I had discussed while discussing the anatomy of the brachial plexus. Around 5 ml of drug is deposited over here after negative aspiration of blood. Needle is then redirected superficially above the brachial plexus, and remaining drug is deposited so as to surround the brachial plexus completely. Usually, a pop is felt when the needle enters the brachial plexus sheath. Care must be taken so as to not to puncture the pleura and the other vascular structures. We should always keep the tip of the needle under vision. The tip of the needle should always be visible. Never inject against high resistance. An opening pressure of more than 15 psi indicates intraneural placement of the needle, and the needle should be withdrawn. Nerve stimulation of at 0.5 milliampere at correct position of the needle is often associated with motor response in the arm, forearm, or hand, but is not essential as long as the plexus, the needle tip, and the spread of the drug around the plexus are visualized. For continuous supraclavicular nerve block, again, the technique is similar to the single shot technique. After locating the tip near the plexus, a catheter is introduced through the needle and advanced for 3 to 5 centimeters beyond the tip of the needle. Catheter position is confirmed by injecting saline and simultaneously visualizing the spread through the ultrasound. Catheter is then fixed on the skin using adhesive tape. Well, coming to the complications. Pneumothorax is a known complication, as we know that pleura lies quite nearby. There can be intravascular injection because subclavian artery, the dorsal scapular artery, the transverse cervical artery all lie close together in this region. Phrenic nerve palsy has also been seen. Rarely, Horner syndrome can be observed. Now we'll discuss the infraclavicular brachial plexus block. Again, the indications of this block include any upper limb surgery below the shoulder level. Contraindications to this block include patient refusal, infection at the block site, or severe coagulopathy. Infraclavicular block blocks the brachial plexus at the level of cords. Cords surround the axillary artery, with lateral cord being the most superficial and the medial cord the deepest and medial to the axillary artery. The cords, they end in terminal and non-terminal nerves. The terminal nerves are the musculocutaneous, the median, the radial, the axillary, and the ulnar nerve. Stimulation of motor branches of the terminal and non-terminal nerves while performing the nerve block helps in identification of location of tip of the needle and in manipulating the needle accordingly. We'll start with the landmark-based techniques. The first technique is the vertical infraclavicular approach. The patient is placed supine with head turned towards the opposite side. Midpoint of the clavicle, that is between the jugular notch and the acromion, is palpated. Needle is inserted just below this point in a vertical direction from ventral to dorsal. Plexus is usually encountered at a depth of around 4 centimeters. Needle should never be angulated medially and should never be inserted for more than 6 centimeters. It increases the risk of pneumothorax. If the needle placement is unsuccessful, we should come out and direct the needle caudally. There's another approach. This is the pericoracoid approach. For this approach, we again place the patient supine with head turned towards the opposite side. The coracoid process is palpated. For palpating the coracoid process, we should start from the jugular notch, from the suprasternal notch, and we should move our fingers laterally in the infraclavicular area. The first bony landmark that is identified, that is felt, is the coracoid process. A point is then marked, which is 2 centimeter caudal and medial to this point. Needle is inserted vertically from ventral to dorsal direction. Again, the plexus is located at around 4 to 4.5 centimeter depth. Medial direction of the needle should be avoided, as it can lead to pneumothorax. The risk of vascular puncture is high with this technique. By locating the infraclavicular brachial plexus, the nerve stimulator is initially kept at around 1.5 milliampere, and a response in distal upper limb is elicited. Once the response is elicited, the current strength is gradually reduced to 0.5 milliampere and the needle is slowly advanced. The endpoint is when the twitches are obtained at around 0.5 milliampere. Typically, around 25 to 30 ml of drug is deposited for this block. For surgical anesthesia, again, we can use ropivacaine 0.75% or injection ropivacaine 0.5%. For post-operative analgesia purpose, injection ropivacaine 0.2% or injection ropivacaine 0.125% can be used. For continuous infraclavicular brachial plexus block, the needle insertion is same as a single shot technique. Again, once the plexus is located, the catheter is threaded for around 3 to 5 centimeters beyond the tip of the needle and then fixed with a sterile adhesive tape. An infusion of 0.2% ropivacaine or 0.125% bupivacaine at around 3 to 5 ml per hour can be started for post-operative pain relief. Infraclavicular approach is better suited for continuous techniques. It helps in better fixation of the catheter and lesser chances of displacement. Now, for ultrasound-guided infraclavicular brachial plexus block, again, the patient is placed supine with head turned towards the opposite side. The arm is abducted to around 90 degrees and flexed at elbow. This makes the brachial plexus more superficial and helps in better visualization of the pectoral muscles. The coracoid process is palpated. After disinfecting the skin, a linear high-frequency probe is placed in parasagittal plane just medial to the coracoid process and caudal to the clavicle. First of all, axillary artery is identified, usually at a depth of around 3 to 5 centimeters. Pectoralis major and minor muscles are identified. They lie superficial to the artery. The cords can be seen at somewhere around 5 o'clock, 7 o'clock, and 11 o'clock position. The cords may or may not be visible. The probe can be moved medially or laterally for better visualization of the cords. The needle is inserted in plane from capillate end of the probe and aimed at the posterior aspect of axillary artery. The needle tip should, for successful placement of this block, the needle tip should be below the pectoralis minor muscle. If we are using the nerve stimulator along with the needle, then first of all, the twitches of the flexors of the arm and forearm may be elicited because of the stimulation of lateral cord. And then the twitches in the extensors of the arm can be seen because of the stimulation of the posterior cord. Once the tip of the needle reaches posterior aspect of the axillary artery, 1 to 2 ml of saline is injected to confirm the position of the needle, and then local anesthetic is deposited. Typically, drug surrounds the axillary artery in a U-shaped fashion. If proper spread of the drug around the artery is not seen, the needle may be redirected around the artery to deposit the drug properly. For continuous infraclavicular brachial plexus block, the needle insertion is the same as the single shot technique. Again, once the tip of the needle is at its appropriate position, the position is confirmed by using 1 to 2 ml of saline, and then the catheter is threaded for around 3 to 5 centimeters beyond the tip of the needle. Again, the tip of the catheter should be reconfirmed by injecting 2 to 3 ml of saline through the catheter. And once we are confident the position of the catheter is at the appropriate place, the catheter is fixed using a sterile adhesive tape. Now, complications of the infraclavicular brachial plexus block include pneumothorax, the vascular puncture, since the axillary artery is very nearby. There can be rarely phrenic nerve palsy as well as Horner syndrome. There is another approach to infraclavicular brachial plexus block. This is the costoclavicular approach. This is an ultrasound-guided technique for giving the infraclavicular brachial plexus block. Now, costoclavicular space, it lies just below and deep to the midpoint of clavicle. The space is anteriorly covered by the subclavius and the clavicular head of the pectoralis major muscle, and it posteriorly by the anterior chest wall. The contents of the space include the cords of the brachial plexus, the axillary vessels. All the three cords, they lie close together in this space. The lateral cord is the most superficial and anterior of them. For costoclavicular technique, the patient is again placed supine with head turned towards the opposite side and the arm flexed at around 90 degrees. A linear high frequency transducer is placed parallel to the axis of the clavicle. First of all, the axillary artery is identified and all the cords are identified with the help of ultrasound. The needle is inserted in plane from lateral to medial direction, targeting at a point that is lying in between the three cords. Once the tip reaches the cords, its position is confirmed by injecting 1 to 2 ml of saline. After confirming that the needle is at its appropriate place, around 20 ml of local anesthetic is deposited after negative aspiration of blood. The advantage of this technique is since all the cords, they are lying close together, so there is a faster onset. And usually, like in supraclavicular block, there is sparing of inferior trunk, which is not seen since all the three cords are lying together. The catheter can also be threaded in this approach by threading it for around 3 centimeters beyond the tip of the needle. The catheter is then fixed using a sterile adhesive dressing.